Hayalperestlerin, risk alanların, denemekten korkmayanların cesaretinden doğduk. Bizi asla yarı yolda bırakmayan o sesin rehberliğiyle ilerlemeye ve öğrenmeye devam ediyoruz. Bunun için varız. Bu yüzden gece geç saatlere kadar lambalarımız sönmez. Elveda demek hem hüzün hem de gurur verir. Her şeyi sorgulayarak ve merakımızı besleyerek, dayanıklılığımızı test ederek, sınırlarımızı aşarak, ilerleyerek ve yeni ufuklar açarak yeni bir yol buluruz. Yeni icatlar çıkararak, kendi yolumuzu çizerek. Burası fikirlerin doğduğu ve yeni fikirleri doğurduğu, bizim de doğduğumuz, birlikte büyüdüğümüz ve yükseldiğimiz yer. Burası Yakın Doğu Üniversitesi.
You're welcome again to our third session of the symposium, dear participants and dear speakers. So this is the last session, and we have some speakers, guests from different disciplines, and I think it will be very interesting also for everybody. So I would like to begin with our first guest, Professor Dr. Deniz Seyrek İntaş. She was born in Germany, and she completed her secondary education, which she started in Germany at Bursa Girls High School in Turkey. Between 1980 and 85, she studied at Bursa Uludağ University Faculty of Veterinary Medicine and graduated with the third place. After graduation, she started to work as a research assistant in the Department of Surgery of the same faculty. In 1987, she went to the Equine Surgery Clinic of Gisen Justus Liebig University Faculty of Veterinary Medicine as a YÖK scholar and completed her doctorate in 1993. She returned to Turkey in 1993 and received the title of assistant professor in 1995, associate professor in 1998, and professor in 2004. Between 2005 and 2008, she received the title of associate diplomate of the European College of Veterinary Diagnostic Imaging by receiving specialization training on diagnostic imaging techniques at the Faculty of Veterinary Medicine at Gisen Justus Liebig University. Retiring from Bursa Uludağ University in 2018, Professor Dr. Deniz Seyrek İntaş has been continuing her studies in the field of equine surgery and radiology at the nearest University Faculty of Veterinary Medicine in Nicosia. Since then, in 2021, she was appointed as the dean of the same faculty. She is married and has 2 children. So please, Professor Dr. Deniz Seyrek İntaş, I want to invite you.
Hi, good afternoon, everybody. I'm back again, and dear chairperson, thank you very much for introducing me so nice. And I must apologize for my rough voice. I caught a flu, and now it's settled in my vocal cords. But I'm happy to be with you anyway. So I hope you enjoy my speech nevertheless, and I'll try to give you a short overview of the applications of radiation in veterinary medicine. And well, we had many very, very interesting speeches before, so I won't go into details of the technical parts, but I just want to highlight the aspects of veterinary medicine, because there are some similarities and some discrepancies. And today I'm going to first introduce the application areas in veterinary patients. Then I will try to introduce the diagnostic imaging techniques briefly, which are utilizing X-rays. And with this, I will try to mainly emphasize the difficulties and factors having the potential to cause health concerns in humans who are trying to take these images, for example. And this will be divided into small animals, exotic pets, and large animals. A very short comment on radiation oncology, and then I will finalize my speech with a summary on suggestions to improve radiation protection in veterinary medicine. Actually, I'm sometimes often surprised about people who are wondering that they say, "Oh, are you also taking X-rays of animals?" And well, we do actually. And radiology is the first modality, of course, we apply for diagnostic imaging because it's the most available one. It's easy to learn and available everywhere. Then the next technique using X-rays is fluoroscopy and followed by computer tomography. A few words to scintigraphy will complete the diagnostic part of radiation applications. Then a few words to the therapeutic radiation, which comprises radiation therapy and nuclear radiation therapy. So here we have a comprehensive list of indications for taking radiographs in animals, and trauma are the most important reasons, and there are often injury to the locomotor system, the thorax or abdomen. And similarly, firearm injuries are also very, very common because some people find it interesting to shoot on animals or even think this is a kind of sport to shoot cats and dogs, and then you sometimes incidentally find some bullets in their bodies. Dental problems are the icebergs we also see quite often, and then you can have an insight of the roots. Firm body ingestion and firm body penetration are also very common, especially in young individuals who like to play and then suddenly they have eaten up their toys. Abdominal masses, organ functions, these are mostly evaluated in adult animals or older animals, and in general, all diseases of the respiratory, the digestive, the urogenital, and also the cardiovascular system are investigated with X-rays. Some developmental skeletal diseases, such as hip dysplasia, elbow dysplasia, or osteochondrosis, are also diagnosed with radiography. Staging of oncology patients, as we have heard quite a lot today, is also starting with radiography. Patients who have abdominal pain, fever of unknown origin. So I can continue just for 2 hours, and this list will continue. So all the indications are quite diverse and similar to the indications we may see in humans as well. So what are the potential problems that may affect human health? So especially the staff in the radiology unit or patient owners or students, etc., who are involved in the radiography procedure. We often find that general rules of radiation protection are broken and or misused actually, and it doesn't make a difference between human medicine and veterinary medicine concerning radiation protection. So ALARA, we heard about that quite in detail, applies also to our patient. We have to keep our distance, and this is saving a lot of harm with the inverse square law. Aprons and all the protective clothing have to be worn, but this is also sometimes not performed. A low number of staff should be kept in the radiography room when the exposure is done, and the radiology room should be designed according to regulations which shield the room from the surrounding. Optimal technique, such as a certain number of X-rays, exposure values, collimation, centering, artifacts, processing, storing, and all these things can also help us to save radiation. Dose meters are also carried by us, and with these we can control and follow up the radiation dose we are getting, and they should of course be worn under the apron, not in front of it. So potential problems in small animal practices with small animals, I mean cats and dogs. It can happen that sometimes patients are uncooperative because they are painful, or they are frightened, or they're just annoyed by so many foreign people, and to be disturbed from home and separated from home. And then they have to be handheld for positioning. And also their small size is a difficulty, because then you need care and your fingers, careful fingers, to hold them properly. Positioning under sedation or anesthesia could be a solution, and this is done in the UK as a rule, as a general rule. So animals are only imaged with X-rays if they are under anesthesia, but this is not followed by many other European countries as well, and we also don't do it because insufficient organ function or debilitating and or compromission of organ functions due to trauma or whatever can cause a complication due to anesthesia. So before you have any possibility for doing some lab work, some blood work, this option should be only done with care. So high-risk patients cannot easily be anesthetized. And then this happens, of course. You see very small patients people try to be careful and handle them with their hands, but then they are caught by the X-rays, and I often still today, I get these kinds of images where hands and feet sometimes and other pieces of anatomy, of human anatomy, is included in the image. Exotic pets are even more difficult than small animals. These are not used to be handled at all, or some of them, especially the wild ones. They have a very high heart rate and respiratory rate, and this causes also some movement, and they are of very small size, so handling is really, really difficult. If you have a rodent, you can use some specific forceps like these here with the rubber mouth, which can hold the extremities in the correct way, or you can use some strings or some gauze or tape, adhesive tape, which can fix them on the cassette or on the image receptor. Birds are more difficult because they are extremely excited and frightened, and they often need some sedation. But if the general condition is not appropriate for a sedation, then you need other means of restraint, such as these devices here, where you hold it, the patient on the table with some protective gloves or fixing devices or tape. And here you have some masks where you can also apply some volatile anesthetics. Reptiles can be fixed on the cassettes and also put into plexiglass boxes where they can be fixed, and this is a little bit easier compared to birds. Large animals, especially horses, very often need to be x-rayed, and there we often do some bedside radiography. That means we have to catch our x-ray machine and laptop and go to the barn or to the pasture where our patient is waiting for us. And this is necessary sometimes because they don't have any transport vehicle, or the injury of the patient is too severe to be transported, or sometimes pre-purchase examinations are done at the place where the horse is standing, because you need a manege maybe, or large areas for trotting the horse, etc. So why is it difficult in horses? Because handling is also not so easy. Of course, well-educated horses and horses with a calm character may be large, but they are easy to handle then. They will listen to their owner or their groom. But nevertheless, they can be, when they are injured or painful, they can be dangerous. And so you have to take some precautions. Cassettes have to be often handheld, because if you are not in your clinic where you have these mounted, ceiling mounted holders, then you have to do it with hand holders, with manual devices where you are carrying the cassette and hold them in place. And if you have some flexed images, for example, like you see on the image left down, then you have to hold it by hand, because otherwise you cannot do the position properly, and then you're very close to the beam, and you have to take care, even if you have gloves on, to get your fingers out of the beam. Horses require high exposure rates because they are so large, and the distances which have to be overcome are large, and this is also a handicap, because the higher the exposure, of course, the higher the rate of also secondary radiation, which will affect us. Another important point is that we need a high number of helpers. If you count here, the minimum number is 3. One is holding the horse, one is holding the x-ray machine, and the third one is holding the cassette. And if this is not sufficient, then sometimes has to position the horse in a certain posture to take the correct angle. And then you have 4 people who are actually involved in the x-raying procedure. Pre-purchase examinations in horses should actually be done before a horse should be bought for a certain purpose. although this is not done at a level which would satisfy either vendor and the client, it is to a certain degree done in the state stud farms in Turkey, and we have 4 of them. And every year they are selling 120 to 150 elite 2-yearlings each year, and these are experiencing a pre-purchase examination where we are taking 12 to 16 minimally, and in case of clinical evidence of any pathology, up to 20 exposures per horse. So if you multiply this with all these remaining numbers, there's quite a huge number of x-rays which are done, and these examinations are usually done in the summer season, and you'll have only a limited number of staff helping you, and these are uneducated, uninformed people who are grooms or animal handlers, and they are reluctant to wear these protective aprons because it's too warm or it's too heavy for all the time, and then you are struggling with them to keep them protected. So another X-ray utilizing technique is fluoroscopy. This allows a real-time X-ray imaging in the operating theater, where we use it for orthopedic surgery. And there we assess fractures and dislocations, and we use it to see if they are reduced or not, the alignment and the positioning of the implants, and especially in spinal surgery, we try to localize the anatomy. Another area is the catheter lab. There, fluoroscopy guides the catheters under imaging control, and we use them for diagnosing and also occlusion of abnormal vessels such as PDA or portosystemic shunts, or if you have to place a stent into the trachea, because tracheal collapse is often a problem in chondrodystrophic dog breeds. Another area is a swallowing study, or the observation of gastrointestinal motility, which is also done with fluoroscopy. And here we have a certain time we can use fluoroscopy or the X-ray stream over time. So fluoroscopy uses ionizing radiation and is capable of causing harm to patients and also to the technicians which are helping us, and it must be used carefully and restrictedly. So stent placements and vessel occlusions are always time consuming, so we have to be careful in this way as well. Excuse me. Computer tomography, it uses also X-rays, and here we have cross-sectional images of the patient, and image formation is based on the differential attenuation of X-rays in tissues and organs, and the X-ray tube rotates around the patient in the gantry, and here the X-ray beam does not spread out in all directions, but it is collimated to a certain size, and the attenuated X-rays are captured by the detectors, and we get slices of 1 to 10 millimeters. And these data we get from the detectors are sent to the computers, where they are converted into images by using complex mathematical algorithms. And here you can see some computer tomography machines used in small animals and also in some parts of horses. Here we have also potential problems that might affect us. The radiation dose, we heard of that, is much, much, much higher compared to conventional radiography. And here I found in my references that it's up to 50 times higher. We heard it can be up to 100 times higher than the images which are done in a 3D radiographic study, for example, of the thorax. The examination requires heavy sedation or general anesthesia in order to prevent motion blurring and artifacts. And the operator of the equipment is located usually outside of the CT room. This is good because then we can at least prevent him from getting any radiation. And in the image below here, you can see a cat in a mousetrap, which tries to give the cat the required positioning for scanning without using a general anesthesia, but only maybe a light sedation. Scintigraphy also uses radioactivity, and here we have a radiopharmaceutical which is administered to the patient, and the distribution of this chemical in the body is monitored, and the gamma radiation is detected by a gamma camera. This technique is not only a morphological investigation, but also a functional imaging technique. And here we can find localizations of obscure reasons of lameness, especially in horses. Here the patient serves as the source of radiation, and it's not the X-ray tube or any other devices or chemicals. So although scintigraphy is not very widespread in the veterinary practice, actually, as far as I know, there's no facility in Cyprus and also none in Turkey. But there are many areas of application to do these scans. It's very beneficial for bone lesions, to find bone lesions, thyroid scintigraphy, especially in cats, because in geriatric patients we often find hyperfunction of the thyroid. Renal scintigraphy is important to evaluate the function of the kidneys. Pulmonary and liver scintigraphy, GI tract scintigraphy are also common areas of application. And we also heard of combining different imaging techniques, such as the positron emission tomography in combination with a computer tomography image, a PET CT, and a PET MRI is also possible. Here on the right-hand side, we can see some images starting from the upper one. The left image is an image of a cat showing the thyroids in the neck area, and also in the canine patient, you can see nicely the salivary glands and the thyroids, which show an accumulation or activity of gamma rays. In horses, we use this usually in the extremities to find out the reason for lamenesses. And in the images below, we see these hybrid images showing the scintigraphy image on the left-hand side, the red ones, and in combination with the CT images on the right-hand side. And in the center, we have the combination of both, where we can compensate the missing morphological detail, that we can nicely see that the hot spot is located in the navicular bone, as an example. Actually, scintigraphy is limited to academic institutions and specialty hospitals because the equipment is very special and very expensive, and it needs some radiation safety regulations after the study has finished. And here is the patient, the source of radiation, and here we have again relatively high radiation doses, and they can affect both the animal and the examiner. Here are images of the scintigraphy unit in Ghent and in Germany, where you can all see different animal species under examination. So after we have come to a diagnosis, we need to confine and isolate our patient until the radiation emission falls below legal limits. And in many cases, that means an overnight stay or up to several days, isolation of up to several days. And here we have to indicate that we have radioactivity. We have to use protective coats and gloves and covers of our shoes when we want to, or when we have to enter to look after the patient. So in the center, you see also a box for dogs, and the left image shows some pipes which are regulating the radioactivity coming from volatile radiopharmaceuticals. So radiation oncology is a topic we had much more information already before, and this has even less applications in veterinary medicine. This has several reasons. Actually, veterinary patients have usually or mostly no health insurance which cover all the costs, and these are very expensive therapies. On the other hand, animals have a shorter life expectancy compared to animals, and as these equipments are developing all the time and are very expensive, there are only very special hospitals which offer these kind of therapies. Generally, we know that there is a curative therapy and a palliative radiation therapy. The first one tries to cure the patient completely without any remission, and the palliative one just tries to relieve the patient of pain and other symptoms or improve the quality of life in animals with advanced cancer. So applications are, as we know from human medicine external beam radiation, which is called teletherapy, and brachytherapy or plesiotherapy, and we heard of biological targeted radiotherapy. This is more often applied in cats with hypothyroidism. And on the images on the right hand side, you can also see patients treated with the strontium 90 with plesiotherapy, treating superficial tumors, mast cell tumors, or squamous cell carcinomas of the nasal plane in cats, for example. So, unfortunately, these techniques are not available to us yet, hopefully, someday. So, the question is now, how can we optimize radiation protection despite all these difficulties and handicaps? So, we have to minimize the time of radiation exposure because cumulative effects are really harmful, and we have to apply the inverse square law. We have to maximize the distance from the source. So we utilize hand-free methods, maybe by applying some sedation or non-manual restraint techniques. And in this means, we have to educate our employees, our technicians, to be more careful and obey all these radiation protection rules. We have always to use proper personal protective equipment, and wearing is not enough. You have to get your fingers out of the primary beam. Doesn't help to use a glove or an apron because this only protects against secondary radiation and not against primary radiation. And we have to handle them properly because if you throw away your gloves and aprons and they are broken, this is the result. And then you think you are protected, but actually it's not the case because there are cracks, and this has to be checked every year. We need a proper planning of the radiography room because I saw more than one veterinary practice where people have just prepared a corner and used some separators to place their X-ray machine, and it's just a piece of plastic which separates the X-ray machine where they are using the X-rays, and all the people around which are in the examination room just a few meters away are getting all the X-rays, and this shouldn't be. So we have to consider the position of the room in relation to the other rooms, because maybe we have to move the patient from the anesthesia room or from the operation hall into the radiology unit and so on. And it should have a sufficient size. So we need at least a 2-meter radius from the primary beam, which is the control area. And we need shielding of the walls, if present, of windows, and if there are any rooms upstairs or downstairs, of the ceiling and floor, because we have to consider that we might use a horizontal beam maybe. So there's also a responsibility of the vendors, the suppliers of X-ray machines, because there I'm also not sure if they do their task properly. They are happy to sell X-ray machines, but afterwards you rarely find them. So they should ensure that X-ray machines are safe and functioning properly. We need a good beam filtration and a collimation device, and the service of the X-ray machine should be done at least once a year by a qualified engineer. And this, the last item, has been included by myself, because I think vendors should only be able to sell their products to veterinarians or companies who are authorized and licensed as radiologists. And if a person has got this education, then we could assume that he will do its best to keep the rules. We should also keep proper reports and record all occupational injuries, such as work-related injuries or illnesses or fatalities, and use a logbook. And we should adequately train and also keep training records of our staff and the technicians and everyone who's working with us. And our employees should get obligatory refreshing classes on radiation physics, radiation protection, and X-ray techniques. This is obligatory every 5 years for veterinarians in Germany, and this is not a rule in our country. We have to minimize the number of non-diagnostic films, and we should avoid the need for repeat exposures. That means we have to position patients carefully and spend some time, be patient with them, and shouldn't force them to lie in a position which is maybe uncomfortable or painful, because they cannot vocalize or articulate their feelings. And if we are patient and calm, after a while they will recognize that it's not that bad to stay still, and then we can do our exposure. But otherwise, in a rush, you will have many repeats, and this should be recorded, of course. And at the end of the year, we should look in our archives to see how many diagnostic radiographs did we take and how many are really in vain or should have been improved or have been done because we were too busy. So we have to record each radiographic exposure we take, and we have to archive this, and this should be done in a daybook for radiography, and there we should record all the date, the animal ID, exposure factors, the quality of image, and the means of restraint, because at the end, finally, the veterinary radiologist is responsible for all the exposure and the health protection of all his employees, clients, technicians, students, and other people from the public which are passing on our radiography unit, for example. So controls should be optimized, and there is an International Radiation Protection Association, and we are all members of this association, and there's also a National Radiation Protection Association. And actually we have to be prepared because they have the power to make unannounced inspections, and these would be good to catch some inappropriate applications. So we have to obey protective rules in the field. Also, if we take our equipment to the field, and should behave as if we were in the animal hospital. And if we take images like this here, it's not a solution to crop it away, but just to avoid and not include any of our extremities in the primary beam. And then if at the end we can use this mnemonic, pink camels collect extra large apples, this can be used as a checklist if we have done everything properly. So P stands for patient preparation and positioning, C for centering, the next C for collimation, E is exposure, L is labeling, and A is artifacts. And if all these items are okay, then you can press your button and take your X-ray. So I would like to close with a summary of what I've told you. So I've tried to give you an overview about X-ray applications for diagnostic and therapeutic purposes in veterinary medicine in a very short wave. And I tried to point out the difficulties and problems during the imaging procedure based on different animal species and which could have an impact on human health. And then I tried to give some suggestions on how to overcome these problems, to avoid any radiation hazards, and to provide a good education to students and colleagues. Because often I hear from my students at the end of the radiology classes, and they say, "No, teacher, I made a summer practical last summer, and the veterinarian asked me always to take X-ray images and hold the patients for X-rays, but he never gave me an apron, or I was not allowed to take an apron for radiation protection. So what about this? I think this should have an end." Thank you for your attention.
Thank you for your nice presentation. I think there is no question. Thank you, Dr. Deniz Seyrek and Taş.
You're very much welcome. Thank you too.
Dear participants, last session second speaker is Dr. Dilek Arsoy. Firstly, I would like to introduce Dr. Arsoy briefly. Professor Dr. Dilek Arsoy completed her secondary and high school education at Bursa Girls High School, her university education at Uludağ and Ankara University, Faculty of Veterinary Medicine, and her doctoral education at Ankara University, Department of Animal Science on the field of reproductive biotechnology and animal breeding. Dilek Arsoy received her postdoctoral training on reproductive biotechnologies in farm animals and the use of nuclear techniques in reproductive biotechnologies at Utrecht University, Faculty of Veterinary Medicine, Netherlands. At the same time, she has certificates such as Strategic Plan, Food Safety Management System Documentation Training, Quality Management System Standard and Documentation, International Audit Training, Industrial and Medical Radiation Protection, and Project Management Circle, so on. She worked as a lecturer at Ankara University, Faculty of Agriculture, Department of Animal Science, and worked in the Turkish atomic energy, nuclear biotechnology, radiation protection, international project management at the Nuclear Animal Health Research Center. Currently, she is working at the nearest university, Faculty of Veterinary Medicine, as head of Department of Animal Science and Nutrition, Vocational School of Health Science, as head of Laboratory and Veterinary Health. She continues to serve as a founding faculty member of the Department of Animal Science in the Agriculture Faculty. She is a member of nearest university Animal Ethics Committee, Izmir Chamber of Veterinary Public Health, and European Food Safety Authority Scientific and Technical Support Committee. Her work and education areas is reproductive biotechnologies and nuclear medicine techniques, animal breeding, animal rights and welfare, livestock policies and economics, veterinary public health, and One Health. She participated in many national, international scientific projects on these subjects as a researcher and project coordinator, and made scientific publication. I would like to invite Dr. Dilek Arsoy for her presentation. Thank you.
Thank you. Thank you. Thank you very much for your invitation to the ionizing radiation and its effects on human health symposium. And good afternoon for all participants here. My subject is a nuclear technology regarding with the veterinary public health and also a nature. And I will try to be overview as I can. And this is the very critical and also another side of the nuclear technology issue. And in terms of animal, human health and plant, and also food safety. And this approach is regarding with the One Health concept, plant, animal, human, and environment. And because the system is holistic, the One Health system is holistic, and we cannot separate some of the living organism from the other. As you see, with the emergence of the peaceful use of nuclear technology in the world, and the use of nuclear reactors has gained importance in the world and also Turkey. In addition, nuclear technology has gained importance is medicine, agriculture, animal husbandry, desalination of seawater, and military submarines and aircraft carriers, ships carrying a large tonnage cargo, and for civil purpose, and also industrial application like a smoke detector. Smoke detector is the very simple nuclear technology, and also constructing sector. The nuclear technology used constructing sector, and everyone knows the baggage scanning with using nuclear technology, and also sterilization and medical equipment, and sterilization of some food use the nuclear technology. And the radioecology in the nuclear technology is a different science in the nuclear technology, and the radio technology that examines the effect of the possible spread of radioactive materials that may arise during the use of nuclear technology, which is used such as wide area on the list of living things, is defined as radioecology. And the safe use of nuclear technology in the fields of medicine, agriculture, animal husbandry, and food safety is important for veterinary public health and is directly related to One Health approach. And for instance, you can see the nuclear technology and application in the food and agriculture and livestock population, animal health, and also human health, and as you know very clearly, and reproduction and breeding, also animal nutrition, sustainable animal production, and food safety and quality. In the plant side is plant breeding, mutation induction, mutation detection, mutation breeding in the plant, and plant biodiversity and genetic resource, insect pest control, especially in the organic agriculture, and land and water management, climate smart agriculture, and also nuclear and radiological. There is a nuclear and radiological emergencies. And what is sustainable? Sorry, one moment, please. One moment, please. Sorry. So sorry. Can you see my slide? Can you see my slide? Sorry, can you see my slide? Sorry.
Now
Sorry.
we can see, but before this, we can see your slide.
One moment, please. There is a mistake, but I don't know why. And you now?
Yes, we can see, but
Okay.
it is not in full screen.
Okay. One moment, please. Now is okay, I think.
Yes, it is okay. You can continue.
Yes, but yes. Yes, what is the sustainable livestock management? So sorry, and sustainable livestock management is fundamental to achieving global food security. It needs to consider both the demand of growing global human population for food of animal origin and the challenges imposed by a changing climate. And using nuclear technique is develop animal health and production practice to help meet this demand while conserving natural resources, and jointly with FAO and International Atomic Energy assist member states in developing and adopting nuclear-based technologies to optimize livestock reproduction and breeding practice that are in line with sustainable development principles, support the intensification of animal production, and optimally utilize the world's natural situation. And how we can use a nuclear and isotope technique can contribute in animal production. And for instance, to determine pregnancy using iodine 125 in radioimmunoassay, and construct whole genome radiation hybrids, panels, and mapping to improve animal breeding, to follow feed intake by grazing using carbon-30, and to assess the risk of disease from infected birds and animal use stable isotope ratios, to develop attenuate vaccines by gamma irradiation of pathogens, to monitor vaccine response, the incorporation of treated thymidine into cellular DNA is used to measure cell proliferation and chromium 51, and to determine of the protein synthesis rate by using phosphor 32, phosphor 33, nitrogen 14, or sulfur 35 incorporation, and to investigate mineral imbalance in farm animals by using phosphor 32, phosphor 33, nitrogen 40, and sulfur 35 incorporation, and also to estimate methane emission, phosphor 32, phosphor 33, and nitrogen 40 or sulfur 35. And as you see, the case of the nuclear and radiological emergencies and the determination and assessment of contamination in the animal and plant. And nuclear or radiological accidents can contaminate agricultural land and produce. Contaminants are substances not intentionally added to agricultural land and products, but present in or on them, and they may include either stable or radioactive material and can originate from natural source or as in the result of human activities. And the most important risk affecting human and animal health and environmental, of course, environmental health is the problem arising from the use of nuclear energy to produce energy. In shortly, the damage caused to the environment during the nuclear technology production process, which replaces fossil fuels, is at a minimum level and is also carries environmental risks that need to be kept under control. And there is two risks in the nuclear energy. And first way, the emission from the chimney are transported in the atmosphere and reach the Earth's surface and living things on the Earth's surface. And the other way is the liquid and solid wastes from the power plant reach river, lakes, or seas, and the living creatures living in these environments and underground waters are affected by these waters. And there are three main nuclear accidents in that time, and there have been three serious accidents in the history of nuclear power. One of them is the 3 Mile Island nuclear power plant accident in USA. The second one's Chernobyl nuclear power plant accident in the Soviet Union, and Fukushima 1 nuclear power plant accident in Japan. And the use of nuclear technology as a weapon, which is disgrace in human history, has also led to the same great disaster, such as the radioactive contamination caused by the bombs dropped on the cities of Hiroshima and Nagasaki during World War II. And there is a two effect, and Meltem Hoca said that in the morning. There are two effects, radiation effect. One of them is the acute effect, the other is the chronic effect. And acute effect, nuclear effect on the plants, we can say the most sensitive tree is pine trees, and to the nuclear radiation as a radiation effect. And the deciduous trees, the shrubs and the herbs showed progressively less radiosensitivity. And lichen is a very strange plant, and lichen-dominated communities are exceptionally resistant. And the radiation sensitivities of cultivated plants, such as vegetables, grains, and fruit trees, are in general similar to those of closely related species that occur in the wild. And an example, lettuce LD 50, those 50 gray, and barley 50 gray, and wheat and between 20 and 30 gray, peach tree 32 and 150 gray, and apple tree 32 and 150 gray. And mammals, in the animals, mammals, and the small mammal species LD50 within 30 days, values range from 5 between 5 and 11 gray. And for instance, the mice LD 50-30 dose is the 7 gray. And for sheep, cattle, pigs, and horses, because the animal is important for the human food, of course, all body LD 50-60 values range from between 4 and 7 gray. And the spaces, the animal spaces is important, but the breadth of animals is also important to sensitivities. And in white leghorn chickens, a dose of 4 gray reduce egg production after 10 days exposure. And hematopoietic death in canines with cobalt 60, 2.60 gray or X radiation dose is 2.28 gray. And insect is unfortunately and seriously resistant species, and to produce lethality in adult insects usually requires about 100 times the dose required for vertebrates. And summary, of course, reproduction is the most important thing, and the lethal dose vary widely among different populations, and acute dose of 0.1 gray or less are very unlikely to produce persistent, measurable deleterious change in population or communities of terrestrial plants and animals. And the other effect is the chronic radiation. In the plant, the oak pine forest is the most sensitive, with the exposure rates down to 20 milligray a day. The lichen community shows by far the greatest radiation resistance, also like a acute dose. And mammals, in the mammals, dog and farm animals, pig, donkey, with 0.1 gray a day show some deterioration in a few weeks and died after a few months of continuous exposure. If with 1 milligray a day, no effect observed. However, if the exposure of 4 milligray a day produced measurable declines in the number of motility and viability of sperm in the dog, and all body gamma radiation to mice at dose rates of between 20 and 200 milligray a day, and on acute exposure, males were more adversely affected than females by chronic irritation. And chronic effect summary is also reproduction is likely to be the most limiting end point in terms of population maintenance, the very critical concept. And sensitivity to chronic radiation varies markedly among different taxonomy. And irradiation at chronic dose rates 1 milligray a day or less does not appear likely to cause observable change in terrestrial animal population. And irradiation of chronic dose of 10 milligray a day or less does not appear likely to cause observable change in terrestrial plant population. And estimated dose to plants and animals under current radiation protection standard, and we accept the dose limit for members of the public station to be 1 millisievert, as you know. And in the animals and in the nature, estimating selected radionucleotides in air and water or in the soil, and estimated the equilibrium dose rates to reproductive or growth tissue from taken soil, water, and air. And the aquatic and terrestrial plant and animal populations share a geographical area in common with the critical human group. that radionucleotide transfer parameters in human food chain PET phase are the same as for other species. And that's why we can estimate for plants and animals and calculate for three different scenarios. And one of them is control release of radionucleotide to the atmosphere. Two of them is the control release of radionucleotide to a freshwater aquatic system and soil, and uncontrolled constant release of radionucleotide from a shallow land nuclear waste repository. And of course, the dose estimate the other subject like your dosimeter. And it is assumed that the aquatic and terrestrial plant and animal population share a geographical area in common with the critical human group. And the dose estimate for plant and animals control release of, In the nuclear accident, radioactive elements such as strontium 90, cesium 137, and iodine 131 scattered as a result of nuclear explosion accumulate in the soil and a significant part in the leaves or plants. Strontium 90 is in the very dangerous category. Iodine 131 is in the dangerous category, and cesium 137 is in the moderate category for all of the environment and living organism. Although the plant absorbs radioisotope from the soil through its roots, the amount it absorbs is negligible. And as you see, nuclear or radiological accident can contamine agricultural land and produce. Contaminants are substances not intentionally added to agricultural land and products. And the most important risk affecting human and animal health, environmental health, is the problem arising from the use of nuclear energy to produce energy. And this example is the radiocesium contaminated in the agriculture fields, and cesium or iodine is the same. And general precaution to be taken for the environment and living things as a result of nuclear accident and exposure to radiation. Distribution of iodine tablets as in the emergency action plan in order to eliminate stochastic and determinist effect for humans, and adult dose of 100 milligram iodine. And iodine tablet intake cannot be applied as a preventative action for the consumption of contaminated food. Taking an iodine tablet protects the thyroid glands against radioactive iodine for about 24 hours. And this is very critical sentences. Iodine tablets should be taken 1 to 6 hours before exposure to radioactive iodine. And this is really very critical. Most of time, of course, nobody can take before 1 or 6 hours before exposure in the nuclear accident. And taking in iodine tablet 18 hours after inhalation of radioactive iodine will not reduce the radiation dose to the thyroid. Areas up to 20 kilometers need to be evacuated when there is a potential to reach 20 millisievert. The annual cumulative dose for humans, the 20 millisievert quotation can be evaluated at the reference level of 20 and 100 millisievert in emergency exposure situation. and areas of up to 20 kilometers need to be evacuated when there is a potential to reach 20 millisievert annual cumulative dose for humans. And also, after the explosion, water, milk, vegetables, and fruits and meat are directly affected by contamination. For instance, after the Fukushima accident, raw milk was found to contain 1,190 becquerel kilogram of iodine, which exceeds the provisional regulatory value of 300 becquerel kilogram. And in addition, radiocesium was detected 54,100 becquerel kilogram, iodine in 1,031 becquerel kilogram of spinach in Hitachi. And this value is exactly a high value for animal and also human. And beef cattle fat contaminated rice straw had unacceptably high level of cesium, and beef distribution was restricted in 4 provinces in that time. And consumption of foodstuff, milk and drinking water is stopped when the accepted levels for the radionucleotide iodine and cesium in foodstuff, milk and drinking water are exceed in emergencies occurring in light water. And yeah, it's finished. Accepted new reference values 2012 for cesium, and in the drinking water smaller than the 10 becquerel kilogram, but before the cesium amount, the accepted amount is 200 becquerel kilogram. And milk and baby food, in the milk and baby food, 50 becquerel kilogram, and meat, vegetables, wheat, and fruit, 100 becquerel kilogram, cattle and horse feed, 100, and before 300 was 300, and pig feed, 80, and before was 300, poultry, 150, and before was 300, and fish 40, and before was 100. And all of the value described again in the 2012. Yeah, and the result, as a result, the use of nuclear technology for peaceful purpose is more common than is known. However, the risk that may arise during the use of technology exists in the field of nuclear technology as in every field, and cause acute, chronic, or fatal consequences in living things. And at the same time, it can lead to disasters that are not easily reversible in a very short time. It is also possible to define as it. And thank you for your attention, and let's all living organisms be safe and one welfare and one health. And I am saying thank you.
Thank you for your presentation, Professor Dr. Dilek Arsoy. And let me check the answer part. There is no question. Thank you for your nice presentation.
Thank you.
This symposium last speakers is Dr. Gürkan Ünsal. I would like to introduce Dr. Gürkan briefly. He was born in 1992 in Bakırköy, Istanbul. He graduated from Near East University Faculty of Dentistry in 2015 and completed his doctorate education at Istanbul University Faculty of Dentistry, Department of Oral Diagnosis and Radiology in 2019. He also completed his undergraduate education at Anadolu University Web Design and Coding in 2021. He is a member of Artificial Intelligence in Medicine Research Group at Near East University, Desham Institute, and the AI for Health Focus Group in a joint project of the International Telecommunication Union and World Health Organization. He is also a member of the Specialty Committee in the European Academy of Dentomaxillofacial Radiology. His research interests are diffusion-weighted imaging in the head and neck region, artificial intelligence application in medicine, and radiographic features of the malignant tumors of the jaws, and oral cavity in various imaging modalities. Currently, he is focused on computer science, deep learning, and the application of the magnetic resonance imaging in dentistry. Yes, Dr. Gürkan, you have the word.
Thank you so much for the introduction. I have the last presentation of today, but the thing is, this is not really a topic which was routinely talking about, because the problem is, this is the last presentation, but I have to say that the dental radiology constitutes 36% of all of the radiology applications in Turkey. When I just saw the statistics in the first time, I just said that dental radiology should not constitute the biggest slice of the pie in Turkey, but this is actually the statistics of the Nuclear Regulatory Authority in 2021. So I have to give you a hint about my content. I know that we are a little bit short of time, so I will pick up the pace a little bit. So the content is about, I'm going to talk about the intraoral x-rays, I'm going to talk about the 2D extraoral x-rays, and I'm going to talk about the 3D extraoral x-rays. I just divided it to the subdivisions because I think that it will be easier to understand if you will just divide them into these parts. We are going to have an algorithm for the sake of clarity, because if you will divide every single technique into three different parts, then I think that it will be easier to understand the main concept. So we will talk about the definitions, we will talk about the indications and the acquisition. So let's start with the intraoral radiographs. They are the backbone of the imaging for the general dentistry. So whenever you go to a dentistry appointment, it's possible that this is going to be the first image that's going to be taken from you. If we are talking about a single tooth problem, or if we are talking about a localized periodontal, which means the gum problem, then it's possible that you are going to have an intraoral radiograph. If not, we are going to talk about the others. So basically, when you think about it, this is just 2D radiology. So what we have is a receptor or a film, depending on the technology that you have. You have an X-ray source and you have an object. So if you will put this inside the oral cavity, then we are going to call it as the intraoral radiographs. We have three different categories in this intraoral radiographs, such as the periapical projections, bite-wing projections, and occlusal projections. Back then, we didn't have any extraoral radiographs that can cover larger areas. That's why we needed a lot of intraoral radiographs. So in order to just go for a routine radiological examination from a patient, we just had to take a full mouth set of radiographs that consisted of this intraoral radiographs that I'm going to talk about. But thanks to the technology, right now we can cover all the areas in a single projection, but it comes with a cost and there are a lot of limitations. What I would like to just tell you in this presentation is we have a lot of applications and the indications are almost completely different. So I have to emphasize them and I have to clarify them for you. So for the intraoral radiographs, as I mentioned before, we have three different parts. One of them is a periapical radiograph that you see on the left side of the screen. We have bite-wing radiographs and we have occlusal radiographs. So when you take a look at them, there are just 2D images. They don't give you a lot of details. You see none of the soft tissues. All you see is the hard tissues or the calcified structures. So you can just guess, well, the indications should be really less, because considering that we are not going to see a lot of parts, but you can get mistaken about it. So let's talk about the definition and then the indications and the acquisition. Let's start with the periapical radiograph. So basically, it just covers the whole tooth. So you can see the crown, you can see the root formation, and you can see some surrounding bone tissue. Over here, I have an example about it. There's an implant and there's just a tooth there. And when you just compare it, just has the same structure. So if you want to evaluate a single structure like a tooth or an implant, then this is the image that you should go for. So I can clearly say that this is the most common image that we take in the dental offices following the panoramic radiographs. And the name is really easy as well. Peri means surrounding in Greek. And if you will put apex, which means it belongs to an apex, so what you have is periapical radiograph. So our motivation for taking this radiograph is to see the surrounding structure and the root. So each periapical X-ray shows all the teeth or all the implant in one portion, and then we just have a hint of the surrounding bone structures. So what are the indications for this? Why do we need this? If you would like to evaluate the apical infection, let's assume that you have a tooth which has a deep caries or a dentin caries as we call, then it's possible that you have an apical lesion at the surrounding structures. So we have to treat the tooth and also the surrounding structures at the same time. So when we do a clinical examination, all we see is the crown portion of it. We don't see anything about the roots if there's not a fracture or if there's not an advanced periodontal problem. So this is our first indication. The second indication is about the periodontal condition. If you have any bone loss, which is just associated with the gingival or the gum diseases, then you can just use this image as well. As you can see over here, we have a premolar tooth and we have an advanced bone loss over there. So we can just evaluate it with a single projection. If you want to evaluate dental trauma, as you can see on the third periapical radiograph, this has the indication of it. As you can see, we have horizontal root fractures, which are really common in dental traumas. Since those teeth are localized at the anterior side, they are the first to just absorb the damage. So we can evaluate the dental trauma as well. So if you're just looking for an unerupted teeth, or as known as the impacted teeth, you can also use this technique. But the problem is, since it's a 2D image, there will be lots of superimpositions, and it will be harder to operate the patient or harder to inform the patient about the current situation. You can also evaluate the root morphology. Everybody assumes that root canal treatments are just easy because you just do a preparation and then you take out the D-vital pulp and you fill it with something. So it should be easy, right? Everybody just says that it's too expensive, it takes a lot of time. Why should I come for 3 different setups and things like that? But it's not the same for every single tooth. As we have the variations for the anatomical structures, we have the same problems with our teeth as well. So we have to be sure about the canal configuration and the root morphology of the teeth. Otherwise, we are just trying to find the root canal without seeing anything at all. So this is not actually a scientific way to do root canal treatment. And after the root canal treatment, if you would like to just do an assessment of the success of the treatment, we will still use this periapical radiographs. So over here, you see that there was a root canal treatment before, which was done, we don't know, days ago. And then you see a missing part of the root. So this is called as an apical resection. You don't have to know the name, of course, but I'm just trying to give you a hint about it. So if you would like to do a follow-up on the apical surgery, or if you would like to see if your endodontic treatment is successful, you can use this technique as well. And of course, the implants, nowadays everybody's going for the implants. Even our students, their goal is to go for the implants right after they graduate. And we don't think it's a really healthy option because it requires some experience. But if you would like to be sure about the healthy condition or the current condition of your implants, then you can go for periapical radiographs, as they can help us with the follow-up or the examination. So over here, what you see is a problem with the implant, which is caused by an inflammation, and we call this as peri-implantitis. So we can also use this periapical radiographs, a simple intraoral radiography technique, for the evaluation of all of those indications. So the acquisition is really easy, as I mentioned before. All we have to do is to put the receptor inside the oral cavity, and we have to think about the object that we are going to visualize. So if we are going to just take an image of the maxillary anterior teeth, then we have to put it at the palatal side of it. If it's parallel to the maxillary anterior teeth, then it's better, because if we will have an angulation, then there will be distortions, which is going to affect our treatment plan and also the diagnosis. And then what we want to do is we want them to be parallel, and we want the X-ray beam to be perpendicular to those. So on the left side, you see an ideal examination with the periapical radiograph, and on the right side, you see an ideal periapical radiograph. So the second intraoral radiography technique is the bite ring radiographs. Right now, we have a different aim. Right now, we don't want to see the periapical region, which means that we don't want to see the surrounding structures at the root side, but what we want to see is, or what we want to visualize is the crowns. So bite ring radiographs include the crowns of the upper and lower jaw and the alveolar crest. Alveolar crest is the bone that's at the interproximal sides of the teeth, and if you would like to just visualize those, then we have to go with a bite ring radiograph. When you think about it, the technique is not different, but the receptors or the films are different, and also the acquisition technique has some minor differences. So if you will align the receptor or the film horizontally, then you can see the interproximal or the contact sites of the crowns, which helps you to diagnose the interproximal caries, the caries lesions which are localized at the contact points. So at the upper right side, you can see that there is a deep cavity, which is at the second premolar at the upper jaw. And if there would be a superimposition between those teeth, then it might be impossible to visualize it. That's why we really need to do the bite wing radiograph. We need to perform them. And if you will just align them not horizontally but vertically, then it's possible to evaluate these bone structures, which we call as the alveolar crest on both of the jaws. Sometimes, if you will perform it perfectly, you can also evaluate it in the horizontally aligned bite wings, but our main motivation just decides for the alignment of the film. Let's talk about the indications. So if you would like to detect lesions, like the caries lesions, then you can use bite wing radiographs. One might just say, can't we use periapical radiographs in order to detect the caries lesions at interproximal side? Yes, you can use it, but that's not our main motivation. If I'm going to use a vertically aligned field, which is a periapical radiograph, then you have to consider this. Periapical radiographs are smaller than the bite wing radiographs. So if I want to evaluate an interproximal cavity, which is localized between just two teeth, then using a bite wing radiograph will increase the effective dose, and we don't want to do this. And if you want to monitor the progression of the dental caries, this is still important. If you want to monitor the health of any restoration, which is done by a dentist, you have to just take a look at those, because just check the bite wing radiograph, which is given at the upper right side. And over there, you see a cavity between the root of the tooth and also the restoration that you can see. So this is not an appropriate way to restore a tooth. And when you just take a look at it in an intraoral way, if you will go for an intraoral examination, it's almost impossible to detect those. Of course, if you're an experienced oral diagnosis or restorative dentistry specialist, you might find out them. But if you are not, then it will be a little bit harder. So you need to use the bite wing radiographs. So assessment of the existing restorations, as you can see on the lower left side, we have a restoration over there, but at a part that we don't have any restoration, we have interproximal caries. And also, if you would like to do an assessment of the periodontal status, as I mentioned before, then we can use the ones that you see at the lower right side. So it's not really it doesn't have a lot of difference between there's not a lot of difference between the periodic radiographs and the bite wing radiographs, but the indications have minor differences, and it's important for us. So the acquisition, almost the same, but we use a different film. And if you will have a horizontal alignment, then you will have this minor difference. Other than that, the thing is the same. You will have the receptor, you have the object, which is teeth in this instance, and you would like them to be parallel to each other, and you will just have this X-ray beam direct to them perpendicular. So this is an ideal way to take it. Occlusal radiographs are our third option in the intraoral radiographs. They are not so popular anymore. I'm not pretty sure if I have to just talk about them a lot. But if you would like to just display a relatively large segment of the dental arcs or arches, then you can use this. For example, at the lower left side, what you see is the maxillary projection, and at the lower right side, what you see is the mandibular projection, which was taken with occlusal radiographs. So it's not really okay to evaluate the periapical structures or the roots or cavities, or if you would like to just do an assessment about the existing restorations. This is not an ideal way. As far as I'm concerned with this radiography technique, back then, when we didn't have any 3D imaging techniques, we used to use this a lot in order to determine, let's talk about indications. So in order to determine the impacted teeth, or in order to detect the foreign bodies, or in order to diagnose salivary gland stones, the dentists used to use these techniques. But the problem is, in 2D dental radiographs, we cannot visualize anything about the soft tissue. Actually, we can visualize some, but we cannot just see the differences between those. So it's not an interpretable image. So on the upper right side, what you see is a nasopalatal canal cyst. So I can see the cyst, but I cannot see its relation with the surrounding structures. So even I can say that I detected a cyst. And can a surgeon use this in order to do an operation on this patient? I don't think so. So when we didn't have the CBCT, when we didn't have CT or MRI, we used to use this technique a lot. And at the lower left side, what you see is a mandibular fracture, something like an oblique or vertical fracture over there. You can detect it. You can just evaluate if there's any displacement between the fragments of it. And at the lower right side, what you see is the salivary gland stones. It's good to visualize them, but they are not really okay if you would like to operate the patient. So the acquisition technique is the same because they are intraoral radiographs. The difference is occlusal radiographs are way bigger than periapical radiographs because of their receptor. So we have different receptors for the periapical radiographs for adults and for the kids, for the bite wing radiographs for adults and the kids as well. And for the occlusal radiograph, we have the same difference. So on the right side, that's a mandibular occlusal radiograph. And what you see is an impacted premolar tooth. Okay, right now we can say that we just detected a tooth, but if you would like to operate it, then we have to just avoid the anatomical structures over there, like the mental foramen or mandibular canal or lingual canal. So how are we going to do this? We need a 3D image. That's why we are going to proceed as the technology proceeds. So in the next step, what we have is the 2D extraoral radiographs. Well, there are dozens of 2D extraoral radiographs, but we are not going to talk about the obsolete ones because there are lots of techniques, but they are not in the routine dentistry right now. So I don't think that we are going to lose a lot of time with this, but of course, we are going to talk about the orthopan tomography, which is also known as the panoramic radiograph, and we are going to talk about the lateral cephalometry, which maybe you are familiar with this about your orthodontic treatment. So if you would like to just visualize the facial structures and both of the jaws, both the maxilla and mandible and the dental arches, then we need to take orthopan tomographs, which are panoramic radiographs. So the technique is a little bit different because right now we are talking about an extraoral radiography technique. The film or receptor is not inside the oral cavity right now, it's at the outside. That's why we call it as the extraoral radiograph. So what we have is we have this reciprocal movement X-ray source. So over here we have the detector and over here we have the X-ray beam source. So it's just rotating around our head, and as it's rotating, it's going to just visualize the parts of the facial structures. That's why we don't have a linear image right now. What we have is a curvilinear variant of the conventional tomography. When you concentrate on the name itself, it says orthopan tomography. So one might say that, well, it's a tomography image, but it's not a 3D image. Yeah, actually, it's a 2D image, or you can say that this is a single slice of a conventional tomographic image. So what we have is, you can see the image at the lower right side, and actually what you have is the panoramic image. And the problem is, as you try to achieve a panoramic image, then you are going to have a lot of distortions and you are going to have a lot of superimpositions. That's why even we have a technique like this, we still need the intraoral radiographs, because if you will just concentrate on this orthopan tomographs, you can see over here that we cannot just visualize some of the caries lesions which are located especially at the premolar area. So let's check the lower right side, and over here you see this is the first premolar tooth, this is the second premolar tooth. You don't have to be familiar with the terminology, just assume that there are two different teeth there, right? So if you would like to just evaluate the interproximal area, then it's impossible to do so because right now I have the superimposition. What I need to perform over here is to go with a bite wing radiograph or a periapical radiograph in order to visualize if there's any cavity. So let's talk about the indications of it. There are lots of indications of it. We just said that it's the backbone, but orthopan tomography is at least as important as the periapical radiograph as well. I'm going to count some of its indications, but they are yet not limited to those. Well, I'm not going to just say that the, number A, number two, number three, number four. I'm not just going to count them, but I'm going to show you examples about it. You can see that the qualities of the panoramic radiographs will be different from each other as we will proceed. So get used to that because that's one of the problems with it. Every single unit or every single device has a different imaging parameter, and it depends on the experience of the technician as well. If they do not know how to operate it, the KVP or MA parameters, then it's possible that you will have underexposed or overexposed images. Yet we are going to give examples to all of them with the indications. So if your patient has a general dental health problem, and if you would like to evaluate it, for example, for caries or for pulp origin diseases, then you can use panoramic radiograph. What we see on this image is there are lots of residual roots, which shows that the patient has a poor oral hygiene, or another possibility, maybe the patient received a radiotherapy from the head and neck area. That's why there is a function loss at the salivary glands, which results with xerostomia, which means dry mouth. So if the patients will have this condition, what they will see will be called as rampant caries because they proceed very fast. So just on a single projection, I can see the facial bones, I can see the maxillary sinus, I can see the hard palate, the mandibular canal and the residual roots, the cortical border. it's actually very useful depending on your indication. So you can also assess trauma, especially for the jaw fractures. What we see over here is that we have a mandibular fracture again. We could just visualize it with the occlusal radiograph as well. But you have to just note that in occlusal radiograph, what we see is the buccolingual extension of it. But on the panoramic radiograph, you can see the supero-inferior extension of it and also the lateral extensions of it. So if you are going to combine the 2D radiographs, like if you will combine a periapical radiograph with an occlusal radiograph, or if you will combine a panoramic radiograph with an occlusal radiograph, what you will have will be something like a 3D image, but it's not going to be an actual 3D image. So we still need the 3D techniques, but we are going to explain them further. So if you are going to evaluate an infection, if you are going to go for an infection evaluation like the sinusitis or periodontitis or periapical abscesses, what we mean with sinusitis over here is the maxillary sinusitis, by the way. So over here, you can see that the general periodontal structure condition is really bad with the patient. So there is a problem with the oral hygiene, and I can just detect the periodontal loss over here. Could I do it with some vertical bite wing radiographs as well? Yes, I could. But the thing is, sometimes the periodontal loss is so advanced, even the bite wing radiograph may not visualize the full portion of it. So we still need, in order to do a general examination about periodontitis. So if the patient has any jaw cysts, let's say odontogenic cysts or odontogenic tumors, then we can use a panoramic radiograph. Okay, so over here what we see, there is let's don't concentrate on the terminology a lot. Let's say that we have an odontogenic cyst, which is localized at the mandible, and we would like to evaluate how we operate it. So if we will have a surgeon over here, he or she would say that, how are we going to operate it? Is it closer to the mandibular canal? Is it closer to the cortical borders? So should we just go for RCT, which means root canal treatment, to those two molars as well? Well, the answer is it can just make us fail a lot. That's why we need CBCT. But we cannot just go for routine 3D imaging for the patients. We cannot just take a CBCT image from all of the patients. So in order to initiate a radiographic examination, then we have to go with the 2D radiograph. So it's a good option to detect a cyst or a tumor, but it's not a good option to operate the patient or do the surgery for the patient. We can evaluate some parts of the temporomandibular joints. We cannot see the soft tissues like the lateral pterygoid muscle. We cannot see the ligaments over there. We cannot see the articular disc, which is so important for us, but we can assess the hard tissues, or we can find out if the patient has a TMJ, which is temporomandibular joint dislocations. So we can find dislocations, we can just see the fractures, or we can see other diseases as well. So on the E, this is a cropped panoramic image, by the way. So on the image D, what you see is the full panoramic radiograph. If you will crop it, then you will see that at the right side of the patient, the condyle has a problem. There is a resorption over there. So it's a better way to visualize it. We don't know the extension of it. We don't know if it affected the synovial fluid over there. We don't know if it affected articular disc over there. But after seeing this, we can actually go for an MRI examination. So this is just going to pave the way for the other 3D imagings. Sometimes the patients have facial bone disease evaluations. Sometimes they need facial bone disease evaluations, and panoramic radiograph is so useful for this. What you see on this panoramic radiograph is a patient with McCune-Albright syndrome. Then what you see is there are radiopaque lesions at the maxilla and also at the ramus side, at the corpus of the mandible. The extension is just beyond the field of view of the panoramic radiograph. So after seeing this, of course, you are going to go for a CT. You can also localize some foreign bodies, especially at the kids, but this is an adult patient, of course. Sometimes you can just find those kind of foreign bodies at the maxillary sinuses or at the, or let's say, you can even see them at the oral cavity. Because of the superimposition, you cannot decide if they're inside the bone or if they're at the buccal side of the bone or if they're lingual side of the bone, but still, it will just help you to detect some of them. After this, of course, you'll just consult the patient with ENT and they will solve the problem. And sometimes we can see the salivary gland stones identification. So over here, what you see is a radiopaque structure, which is localized at the inferior side of the left angulus. We don't know if it's a silothiasis, by the way. We can never be 100% sure because this is a 2D image. So this can be localized at the far posterior side or far anterior side or far distal side. We don't know, but we have some guides for the identification of these radiopacities. And on the right side, you can see it. With a panoramic radiograph, by the way, those are all incidental findings. We are not taking panoramic radiograph to see if there's any salivary gland stone at the patient. You cannot go for it because we have guides. You cannot just take a radiograph which involves ionizing radiation just for the sake of the curiosity. You cannot do it. But on the right side, what we have is a guide for the calcifications that you can see on orthopan tomographics, well, as known as the panoramic radiographs. We just monitor the growth and the development of the patient as well. Over here, what you see is called as mixed dentition. Those are not the permanent teeth of the patient because the patient is around 10 or 11 or 12. We know it because we know the eruption ages or years of those teeth. So you can evaluate the growth and development of the patient as well. Sometimes the patient needs an orthodontic treatment and you can use it for the initial evaluation. If you would like to just proceed further with the orthodontic examination, panoramic radiographs will not be sufficient enough by itself. Let's talk about the acquisition. Right now, we are not talking about internal radiograph, so the detector and the X-ray source should be at the extraoral side. The difference between the other 2D images is what we have has a rotation. So what you will have is you are going to just visualize the jaws from the 360 degrees, and then you are going to have a panoramic image. So the acquisition is simple as this. But as the images will get advanced, we will have more and more artifacts. So there's a biting block, and it's very crucial for us to take an image. If you will bite it a little bit deeper, or if you will not bite it and just put your lips there, then it's possible that there's going to be a lot of artifacts which will make this panoramic radiograph uninterpretable. So on the left side, what you see is not the ideal radiographs. On the right side, what you see is an ideal panoramic radiograph. You see that just depending on the slight differences at the head positioning, you can have a completely different image. On the upper left side, what we have is an upward chin, and at the lower left side, what we have is a downward chin. So, and on the right side, what you have is the ideal way. So there are lots of things to consider, especially for our technicians. And this is so crucial for us because otherwise we cannot interpret some of the structures. I'm not going to really talk or concentrate on the lateral cephalography, but the difference is right now we are not taking a look to the patient from the anterior or posterior side. What we are doing is taking an image from the lateral side. So why do we use it? Well, our first motivation is to determine if there's any craniofacial problem with the patient, like if the patient needs an orthodontic treatment or if the patient has a facial growth disease, then we can just try to find it out with all of the anatomical landmarks that you see over there. So on the left side, you see a skull model, and on the right side, what you see is a lateral cephalograph. So for the cephalographs, there are dozens of anatomical landmarks. Of course, we are not going to talk about them, but they help us to determine the relation between the upper jaw and the lower jaw. So some of our patients has a problem with the upper jaw, or let's say they have setbacks or advancement. So we are here to solve them, but first we need the diagnosis. That's why we need this radiograph. What are the indications? Well, I just wrote 4 indications over there, and they are somewhat similar to each other. Number 1, you need an initial diagnosis. Number 2, you need a treatment planning for the orthodontic problems. And then you need to monitor the treatment progress. You cannot just try to take a CT or CBCT from a patient at every single phase. This is going to have a lot of effective radiation dose, and this is not that's not really appropriate to the Alaro principle. And if you would like to go for an appraisal of the treatment results, you still need this. Let me give you an example. On the left side, what you see is a pre-treatment phase of an orthodontic patient. You see that the maxillary anterior teeth has an inclination, or let's say has an angulation problem. And at the post-treatment stage, what you have is a fixed occlusion. So we can just try to evaluate it with the 2D images in order to lower the effective radiation dose. And the acquisition is the same. But the thing is, right now, the concentration is not about the anterior structures of the facial structures, anterior part of the facial structures. Right now, what we are trying to visualize is the lateral aspect of it. So what you see over here is the panoramic radiograph device, and what you see over here is the lateral cephalography extension of it. So we don't need different devices for those, for the panoramic and the lateral cephalography. That's why we can use them at the same time, which is really good for us because then it's there's a cost-effective thing. And last but not least, we are going to talk about CBCT. Of course, dentomaxillofacial radiologists also use the MRI and CT, and we sometimes interpret the PET data. But the thing is, those are already covered by the radiologist. So we are going to talk about the different modality, which is generally used by the dentist for some reason. So normally in 1982, the cone beam computed tomography was developed for angiography, but subsequently it's applied to maxillofacial imaging. Then until that time, let's say since the late 90s, we are just using it. I know that when I was a student in nearest university, it was 2010, and we used to have CBCT. So we can clearly say that nearest university was one of the first schools in Turkish Republic of Northern Cyprus and Turkey that had a CBCT device. Of course, there's a difference because we don't say CT, we say CBCT. So the difference is about the ionizing radiation's shape. We are not talking about a fan-shaped ionizing radiation over here, but we are talking about a cone or divergent type of radiation there. Of course, we have another two-dimensional area detector, rotating gantry again. So it looks like a panoramic radiograph. We have this reciprocal rotation movements again. So there are some devices which has panoramic radiograph and CBCT even at the same device. We have this in our faculty, but we are going to talk about it. So on the left side, what you see is the cone beam geometry, and on the right side, what you see is the fan beam geometry for a single axial slice. In order to have a secondary reconstruction at CBCT images, we don't have axial slices. So just check the images on the lower side. On the lower right side, what you have is axial slices of a patient. So in fan beam CT or in CT or multi-slice CT, what you do is you just stack all of those axial slices, and what you have is a single image. But you have to say if you would like to go for a coronal CT or you are going for a sagittal CT or an axial CT, because most of the time the voxels of the fan beam CTs are not isotropic. So that's a problem. But in CBCT, almost all of the devices which have the cone beam technology have isotropic voxels. And you have to understand that this is very important for us because we are dealing with root canals, we are dealing with small apical lesions. We need all of those coronal, sagittal, and axial slices. So the acquisition technique is different. What we use is a reciprocal device again, but in the end, what we acquire is the sagittal, axial, and coronal slices again. So the indications, I don't know if I have enough time to just cover all of them, but I'm just going to show the most important one or the significant ones to you. So what you see is the small FUV, medium or large FOV. What is this? What does FOV mean? It means that field of view. It means the area that's going to be covered by your device. So there's a guideline for the CBCT, for dental and maxillofacial radiology. We have to follow these guidelines. We cannot just take CBCT images from our patients because we wanted to see the success of our root canal treatment. We cannot take a CBCT image from our patient just because we want to be sure about our orthodontic treatment. We have a specific guideline for this. If we don't have the indication for a CBCT imaging, then we have to start with the 2D images first. Well, I know that if we will take a CBCT from a tooth, then we can just evaluate it in a better way, but at what cost? I'm going to show the effect of those differences and you will relate to it. I'm going to pick up the pace even more. So when you just check this 2D image, you can say that, wow, the implants are placed inside the jawbone, so it seems like there is no problem, so we can put the crowns on it and the patient will have the teeth and everything will be normal. But if you will have the third dimension with the CBCT, then we have a different scenario. What you see over here is the buccal cortical plate perforation. What you see over here is the lingual cortical plate perforation. So, well, we cannot trust the 2D images because we don't have the buccal and the lingual aspects of it. What else? So, of course, if you want to plan an implant treatment, we have to take a CBCT because we are dealing with the mandibular canal, we are dealing with a lot of accessory canals, and if we will not mind them, then it's possible that we will cause paresthesia or hyperesthesia at the patient, so we have to avoid this. So can we evaluate the TMJ structures? Yes, but unfortunately, as the other imagings that we use in dentistry, we cannot just evaluate the soft tissues with CBCT as well. So the thing is, we don't see the articular disc, the ligaments, or the muscles again. But we can just evaluate the condyle or all of the hard tissues or calcified structures. Well, on the left side, what you see is a cyst, more specifically a subchondral cyst. On the middle side, what you see is an erosion at the condyle. And on the right side, what you see is osteophyte. This is also essential for us, but at the end of the day, what we have to take is an MRI image since it's the golden standard. let's try to concentrate on this periapical radiograph. We see an apical lesion. Is there an apical lesion? Can we be 100% sure? Is there a radiolucent lesion? So if you are not sure about it, according to the guide, if the patient is symptomatic, and if you have a suspicion about a lesion, but if you cannot prove it, then you can take a CBCT image. But you cannot go for a full CT scan. This doesn't have an indication. If you would like to just evaluate a single tooth, then why would I just visualize all of the head and skull and maxillofacial structures? So what we have to perform is a CBCT, which has a small field of view. As you can see, this just covers 5 teeth. So just like a periapical radiograph or a bite-wing radiograph, a little bit bigger than the bite-wing radiograph, and it's a 3D image. What I see over here is the apical lesion. So right now, as I diagnose it, I can just extract the tooth or I can go for a treatment. It's up to the dentist. So over here, let's just check the periapical radiograph at the right side. We cannot be 100% sure about a lesion, but if you will perform a CBCT and if you will take a look at the reconstruction image of it, we can see that there's an apical abscess which just elevated the floor of the maxillary sinus. And well, it's not a popular idea, but we know that some maxillary sinusitis cases are odontogenic sinusitis cases, which is because of the odontogenic infections. Over here, what you see is a dental trauma. There are horizontal fractures at the crowns. And as we have the 3D images, we can evaluate it easily. Over here, what we have is a condyle fracture at the left condyle of the patient. As I said before, we can evaluate the hard tissues in TMJ, but we cannot evaluate the soft tissues in TMJ. But bone fractures, of course, if you have an imaging technique that will cover the hard tissues, then it's okay. Then that's all we need. On the upper left side, you see a panoramic radiograph, and at the maxillary anterior region, there are radiolucent lesions. Is this the airway? Is this an artifact, or is there a cyst? If you're not 100% sure about it, there's a problem. And as you can see, there's no carious lesion over there. You can check the vitality of the teeth with some different techniques. But as we took a CBCT from this patient, what we saw, there were 2 cysts, odontogenic cysts, that cause cortical destruction at the palatal cortical border. That's why we need CBCT. That's why we need 3D images. Of course, the effective radiation dose is higher. So let me give you an opposite example to it. At the upper right side, we just think that there's an odontogenic cyst over here, and we said, okay, let's operate it. We would like to see if it has any neighboring tissues with the maxillary sinus, or if there's going to be a perforation at the maxillary sinus, we would like to go for the further examination. And what we see is just a maxillary sinus septa, and there is not even a cyst over there. But the thing is, there is just like a mucosal growth over here, and as there is a maxillary sinus septa, it just looks like an odontogenic cyst at the panoramic radiograph. That's why we cannot just concentrate on 2D images. And of course, we can evaluate a lot of different structures which are relevant with the maxillofacial structures as well. So, what is the difference in the acquisition? As I mentioned before, the voxel size is really important for us. What we have are the isotropic voxels, which is really important for us. And as we acquire the image, we can just alter the field of view. As you can see on the upper right side, we can just select the specific field of view depending on what we are going to evaluate. If we are going for a fracture, a traffic accident, then yes, we have to go with the image on the left side, which covers almost all of the craniomaxillofacial structures. But if we are just going for the jaws, then we will pick the second one. If we are just going for the teeth, then we can use the ones which has the smallest field of view. Thanks to the new technologies, we can just have CBCT, panoramic radiograph, and lateral cephalograms at the same device. Of course, it's not a small device, but if you can all cover them with a single device, this is really good. Back then, the ways of taking those extraoral images were different, so maybe someone else in the past needed 3 different devices for those 3 different techniques. Last but not least, as the other lectures that mentioned the effective dose, I have to mention it as well. So in the table, you see the differences at the effective doses. We just started with the intraoral radiographs, and what we have was 1.5 microsieverts. So you can say that, well, that's really good. So let's try to start with the intraoral radiographs if we are going to perform a radiographic examination. This is what we are doing. That's why this is the backbone of the dental radiology. As the field of views are going up, depending on the device, our effective doses are rising. For the panoramic radiograph, we have 2.7 microsieverts or 24.7 microsieverts. So there is a huge difference between those levels. It just depends on the units and the devices. It depends on the detector technology, if the patient is adult or a kid, and things like that. For a cephalometric radiograph, we have relevantly, we have an effective dose, of course, because we are talking about ionizing radiation. But what we have is not that much if you will compare it with the multi-slice CT. Please check this out. For the multi-slice CT, if you are going for a maxillomandibular or by all of the jaws examination, what you have is 280 to 1410. And for a small field of view dental-alveolar CBCT, it's even possible to achieve a less dose than 2D radiographs. Let me clarify it again. If we can just limit our field of view according to the complications, according to the symptoms and the findings of the patient, we can even achieve an effective dose which is lower than 2D radiographs. Of course, what I mean is the extraoral radiographs. So the dentist and the technician and everyone else should just consider this. And it's already mentioned, but I would like to emphasize it once again. We have to talk about the stochastic effects. Even though I just said that an intraoral radiograph just has 1.5 effective dose, and even a single photon could cause a change in DNA that leads to a cancer or heritable effect. So we cannot, what we talk about in this table, they are all about the deterministic effects of it. But if we are going to talk about the stochastic effects, we have to follow every single guide and we have to just follow the justifications. If you would like to learn, if you would like to read more references about oral radiology, what I would like to just suggest is the oral radiology book of Dr. White, and the diagnostic imaging book of Dr. Lisa Koenig. So there are like another backbone of the dental radiology if you want to learn more. If you would prefer to read something in Turkish, then I can also advise you to read my lecturer, Professor Dr. İlknur Özcan's book as well. So if you have any questions, I will be more than happy to answer them. Thank you.
Thank you, Dr. Gürkan, for your nice presentation.
You're welcome.
I think there is no question. I think Dr. Meltem will close the symposium. Thank you for all our speakers today.
Thank you so much. I think, yes, she's there.
Yeah. You are mute, Dr.
Yes.
Meltem.
So we came to the end of the symposium, and for me, it was really useful, especially the last session, to hear the point of view of some other disciplines about radiation. And I would like to thank to all our speakers for their very nice, detailed, and useful speeches. So I thank you also, Dr. Seçil. You were ill, I know, and Dr. Deniz also, she was ill, but even if you were ill, you didn't change anything. So I hope that it will be useful to everybody who is watching this symposium, and I want to remind that we will put these sessions in YouTube after, and the people who missed to watch, they can watch after from YouTube. So thank you very much, and I wish you a very nice weekend.
Hayalperestlerin, risk alanların, denemekten korkmayanların cesaretinden doğduk. Bizi asla yarı yolda bırakmayan o sesin rehberliğiyle ilerlemeye ve öğrenmeye devam ediyoruz. Bunun için varız. Bu yüzden gece geç saatlere kadar lambalarımız sönmez. Elveda demek hem hüzün hem de gurur verir. Her şeyi sorgulayarak ve merakımızı besleyerek, dayanıklılığımızı test ederek, sınırlarımızı aşarak, İlerleyerek ve yeni ufuklar açarak yeni bir yol buluruz. Yeni icatlar çıkararak, kendi yolumuzu çizerek. Burası fikirlerin doğduğu ve yeni fikirleri doğurduğu, bizim de doğduğumuz, birlikte büyüdüğümüz ve yükseldiğimiz yer. Burası Yakın Doğu Üniversitesi.